Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Ashinsky of RWJBarnabas Health Medical Group. Thyroid conditions are a very common health issue in the United States, with about 20 million Americans living with a thyroid disease of some kind, according to the American Thyroid Association, and up to 60% of those with thyroid disease are unaware of their condition. On today's show, we will learn about the different types of thyroid cancers, signs and symptoms, and treatment options. We are pleased to welcome Dr. Amanda Laird, Chief of Endocrine Surgery at Rutgers Cancer Institute. Dr. Laird sees patients at Rutgers Cancer Institute and Robert Wood Johnson University Hospital in New Brunswick. We also welcome Dr. Tony Beninato, endocrine surgeon at Rutgers Cancer Institute, who sees patients at Rutgers Cancer Institute and Robert Wood Johnson University Hospital. In addition, both Dr. Laird and Dr. Beninato perform surgeries at Robert Wood Johnson University Hospital, Somerset. Welcome to the show. Thank you both for being here on the show. First, the studio audience would love to know a little bit about your background. So Dr. Amanda Laird, tell us a little bit about yourself, graduation, and why you are where you are.
Oh, gosh. It's maybe a longer story than you have time for. I'm a native of Louisiana. I graduated from LSU Medical School in 2000. I did my general surgery training at Wake Forest and finished in 2005. And initially, I was in a private general surgery practice, but decided to go back and do a fellowship in endocrine surgery. So I did that at the University of Michigan, finished in 2011. And since mid-2012, I've been in the New York area, first at Montefiore, and for the last a little over 7 years, I've been here at Rutgers.
Very nice. And Dr. Tony Beninato, please tell us a little bit about yourself.
Hi, good morning. Yes, I'm originally from New Jersey. Grew up not far from New Brunswick. I did my undergraduate at NYU, medical school at Rutgers, New Jersey Medical School, and then my residency at New York Presbyterian Weill Cornell, followed by an endocrine surgery fellowship at the University of California in San Francisco. Then came back to New York, was faculty at Cornell for a few years before I came here about 4 years ago to join Dr. Laird at CINJ.
Thank you. Thank you both for all your background, and thank you also for all that you do for Rutgers Cancer Institute. So we're going to be talking about endocrine disorders, and especially the thyroid. We hear about the thyroid all the time. People go into their family practice or internal medicine practices or even their OBGYNs complaining that they're fatigued and they want to know about a thyroid profile. So first, what is the thyroid gland and why is it so important? Either of you two.
So the thyroid gland is a butterfly-shaped gland that sits in the lower part of the middle of the neck. In our practice as surgeons, we don't treat the hormone-based disorders of the thyroid. And so those symptoms typically arise if there's a concern that somebody has hypo or hyperthyroidism. And we take care of the surgery piece of that if it becomes necessary.
So what we're describing is that we've got the thyroid gland, which is right here in the neck, usually in the male around the Adam's apple, the woman also in the same area. Of course, most women don't have the Adam's apple. And again, it is an important gland because it does help in metabolism. And that's why people go to their primary care doctors or their OBGYNs and get blood work done. However, sometimes in the office, we feel things that are different than they should be. That's when the doctor goes behind them, puts their fingers by their neck, asks them to swallow, and feels for things. And sometimes we do feel things that are abnormal and send them for testing. So can you tell us the different types of thyroid diseases and the differences between a thyroid nodule and thyroid cancer?
Sure, I could take that one. So patients typically see us for one of a few reasons. One would be, as you were discussing, if there's a hormonal disorder, most commonly hyperthyroidism in the form of Graves' disease, an extremely overactive thyroid. In cases where medication cannot correct the problem, sometimes patients come to us for surgery to have their whole thyroid removed. Then the other large part of our practice is thyroid nodules and thyroid cancer. Thyroid nodules or thyroid goiters are benign growths of the thyroid that can often cause symptoms such as pressure in the neck, difficulty swallowing, etc. And sometimes when we find those nodules, if they're not bothering people, we could just watch them and monitor them over time to see if they grow or change. Or if they're bothersome to patients, that's when we can intervene via both surgical and non-surgical methods for those benign nodules. Now, in a case where those nodules are suspicious for cancer, and we do biopsies in our office to help determine this, those patients would go on to surgery to have various extent of thyroid operations, plus or minus lymph node removals to treat the thyroid cancer.
So once again, we start off at the primary care office or the OBGYN. We do the ultrasound, we do the blood work, we see a thyroid nodule or we see something abnormal. Are there any particular causes of thyroid cancer?
Typically, no. There are rare genetic mutations that can cause also rare forms of thyroid cancer, but for the most part, it just happens. So it's a sporadic process, and there's not been any demonstrable link between lifestyle and the development of thyroid cancer.
So again, we go back. Gland over here, we find something. We either send them to the endocrinologist if we're dealing with manipulation of the hormones. We or the endocrinologist does the ultrasound, sees the nodule or sees something there. That's when we refer them over to you as the thyroid cancer surgical person to do what is necessary. As you have described, sometimes the nodules are benign and we just watch them. Sometimes we find things like Graves' disease, as you would describe, which is the overproduction of the hormones. Initially may be treated with medication, but if we can't treat it with medication or there's secondary signs of something, that's when we send them over to the surgeon for some type of surgical intervention. Otherwise, there may be something abnormal in the thyroid gland, and then we send them over to you for a biopsy for the possibility of thyroid cancer. Are there different types of thyroid cancers?
Yes, there are several types of thyroid cancers. There's the differentiated thyroid cancers, which are the most common types, the most common being papillary thyroid cancer, and then less commonly follicular thyroid cancer. And then there's rare thyroid cancers, such as medullary thyroid cancer that Dr. Laird was referring to, that can run in families, but can also happen sporadically. And then there's anaplastic thyroid cancer, which is a very serious, rapidly growing type of thyroid cancer that is fortunately quite rare.
Okay, so it's important for a family history, as you described, because there are some thyroid cancers that do seem to run in families.
It's unusual. Most thyroid cancer does not run in families, but this particular subtype, medullary thyroid cancer, can run in families, but it also can happen randomly.
So again, the big concern with thyroid cancer is the fact that it can just suddenly show up and you may or may not have signs or symptoms of the disease.
That's right.
So, and unfortunately, do we have any known risk factors for what could possibly? You had said earlier that there's probably no risk factors that are going to sort of keen us towards the thyroid cancer.
So the thing that's been most consistently linked to the development of differentiated thyroid cancers, that's papillary thyroid cancer, which makes up about 85 to 90% of that, or follicular or Hürthle cell carcinomas of the thyroid. The only thing that's really been demonstrated consistently to have a link to that is exposure to radiation. And by radiation, that implies some type of disaster, like, for example, the Chernobyl incident. And even within that cohort of that population that lived close enough, it was really primarily in children. So they saw thyroid cancers in younger patients. But for adults, that would be suspicious. Say, for example, if somebody had a cancer as a child and received radiation, especially for somebody that had it 20 years ago that maybe didn't have the type of focused treatment that they have now, where it's a much narrower anatomic field. But anybody that had, for example, external beam radiation would also have a slightly increased risk compared to the average person. That's not to be confused with things like having x-rays or annual mammograms. None of those things have been linked to an increased risk of thyroid cancer.
So again, important to know, mammograms don't increase the risk of thyroid cancer. Chest x-rays don't increase the risk of thyroid cancer, especially because most radiology places put the lead shield over the person's neck also. When you go to dental procedures for x-rays, they also put the lead shield over the neck. Really, the only one we had to be concerned about back at the time when I graduated medical school back in the 80s was we used to give the mantle radiation for Hodgkin's disease, and that was the biggie at that point. But since that's changed immensely since the 1980s, 1990s, it's much less of a concern than it is at the current time.
That's correct.
So when someone comes to you with some type of cancer, are there different surgical procedures? Are there different treatment options for it?
Yes. So depending on, luckily, most thyroid cancers are found early. If they're found early and confined to one side of the thyroid, removal of half the thyroid or thyroid lobectomy is an option for those patients. If the cancer is a little larger or has evidence of spread to the lymph nodes, then those patients would need a total thyroidectomy. For patients with very, very small cancers, there's a third option of active surveillance for cancers smaller than 1 centimeter. So depending on the patient's personal preference, the size of the cancer, and whether or not it has spread, there are a lot of different surgical options that can be tailored to the patient.
So again, we have a left lobe, a right lobe, and an isthmus running between the two. If it's only confined to one of the lobes, there's a possibility that all we have to do is remove that and then follow up with surveillance afterwards. If it unfortunately has gone across, then we want to, get it out. So we'll do the total thyroidectomy, understanding at the same time that we're removing the parathyroid. So we have to watch the person's parathyroid hormone levels, possibly supplement in addition to watching their thyroid hormones.
We do not intentionally remove parathyroid glands, but because they are so close to the thyroid, they're at risk during the surgery. So we always are very careful to preserve them. And often patients undergoing total thyroidectomy will have to take a temporary calcium supplementation that can usually be stopped after 2 weeks.
And again, this is the reason why when someone has something like this, we want them going to someone like you, who's part of the Rutgers Cancer Institute, because you do the team approach to the treatment, thus having an endocrinologist present prior to, afterwards, and this way we can follow them closely and treat them as best as possible.
That's right. We have access to a handful of resources here that are invaluable. One is a very experienced group of endocrinologists that help us take care of patients with thyroid cancer. So we co-manage many of them. And we also have a weekly multidisciplinary tumor board so that we can discuss as a group of experts coming together what we think is the optimal treatment for our patients. And lastly, we have support with two experienced advanced practice providers that see patients along with us, as well as a navigation program. So from start to finish, patients have a variety of different resources that they can tap into for support along the journey of their cancer care.
Again, because you are part of the Rutgers Cancer Institute with the team approach, it starts out actually with the nurse navigator who gets them into it and gets them put into the right place, has them follow up with the right people. It's something that very few other institutes have. You have a very, very good nurse navigator who helps them get through the system, follows them through the system, and makes sure that everything is done appropriately and at the best quality possible. You also have the experts with you, both the endocrinologists, surgical people such as yourself, radiation radiation oncologists if necessary, oncologists if necessary, to follow them through the complete process. Again, team approach. It's done in a local facility so that the patient's family does not have to travel to New York City, Philadelphia, or anywhere else and have follow-ups there. They can follow up with you guys who are the experts. And again, you are part of the Rutgers Cancer Institute, which, again, leading cancer institute in New Jersey, thus giving them the best possible quality care. You also follow them afterwards, which, again, many places which are not the multidisciplinary places don't do what you guys do. And it's from start to finish the best possible quality care that we can give to people with thyroid cancer. And then, as you said, you discussed the tumor board. You're bringing all of these people together, everyone having their own opinion, coming up with the best possible scenario for that person, bringing in external opinions along with internal opinions. Again, giving the person the best quality care possible. So tell us, after the person undergoes the procedure, how long is the typical recovery from the surgery, and do you also do minimally invasive surgery?
So the typical recovery from a thyroidectomy is about 2 weeks. Usually people will take about 2 weeks off of work, 2 weeks of no heavy lifting, but progressing their cardiovascular activity is tolerated. And then after that time, people can return to their normal activities. There's no restriction on diet or anything like that. As far as minimally invasive options, it's sort of a paradox in thyroid surgery because the thyroid is so easy to access in the neck right here. In particular, cancer operations are done through a standard neck incision right here. There are remote access options for thyroid surgery that we don't currently offer here because they're not really intended to treat cancer, but they're really intended to do is to hide a scar in a remote place for a better cosmetic option. But our scars, we make them in a skin crease on the neck. After surgery, they tend to fade very nicely with the application of sunscreen. And really, the scar is not noticeable. Really, to people who've never met you before, wouldn't realize that you had a neck incision after it's healed.
So, again, as a primary care doctor, I send the person over to Rutgers Cancer Institute. What should that person expect?
So I think it depends a little bit as to whether or not they come with the diagnosis of thyroid cancer, or if we're being referred a patient that has a nodule because there's concern for cancer. So if we take that second one, so a nodule that there may be concern for cancer, but no definitive proof, we offer ultrasound-guided fine needle aspiration biopsy in our office. So the same day that we meet the patient at the first visit, we can also do their biopsy and get them started on the process to evaluation as to whether or not they're going to need further treatment. If they come to us with the diagnosis of thyroid cancer, depending on whether or not they've had all of the imaging that they need, mostly, and that consists of of a more extensive ultrasound than probably they had initially, because we look at the lymph nodes throughout the neck before surgery. Then for the most part, we can have a discussion with them that day about our recommendations for surgery. Thyroid cancer is a little bit unusual in that it doesn't require the extensive imaging that, say, for example, somebody with colon cancer has, because in the vast majority of patients, if there's disease spread, and disease spread is limited to neck lymph nodes, in about 30 to 40% of patients in the lymph nodes right around the thyroid. So it doesn't impact the way that it looks so much on the outside. And it doesn't add much additional time to the operation. But we can plan all of those details from either the initial patient visit, or we can map out recommendations and have a follow-up visit with our patients to then determine the best course of care.
So again, the important thing is the whole team, the fact that it's done well, it's done as a team approach, quality care throughout the whole thing, plus good follow-up afterwards. And that it can be done, as you had said, you get an ultrasound, you can get a biopsy possibly the same day. As an outpatient in the real world, if you don't do something like this, they come to my office, they get the ultrasound, they don't get the report for the ultrasound for about a week. I then send them to someone, and it's a 2-week or 3-week wait to get to the person to be a consult. When they see them in the office, they say they need a biopsy, but they can't do the biopsy at the office that day, so it's another 2 to 3 weeks to get the biopsy. So while you're waiting for that, if I'm that patient, I'm very concerned what's happening. Instead, I'm getting the perfect quality at a better setting.
Yeah, and I'd like to add too that we reserve many appointments for new patients. So one of our quality goals is to get patients an appointment within 72 hours. So if you call us with a new diagnosis of thyroid cancer, chances are you'll be able to be seen that same week. And that's something we're very proud of.
It is very great to hear something like that because, again, in the outside world, it doesn't happen like that very frequently. You know, maybe if I have someone's cell number, I may be able to get them squeezed in somewhere, but it's very, very difficult. And you know, it is cancer. And as soon as I say that word cancer to the patient, they're scared. They want that out. They want something done as quickly as possible. You know, even though thyroid is considered, in quotes, a good cancer because unlike colon cancer, unlike breast cancer, it doesn't spread the way, it usually doesn't spread the way that those do, you know, requiring much more extensive surgery, chemotherapy, radiation, it still is cancer. And it is a very scary thing for that. Now, is there any difference in the prominence of thyroid cancer in men versus women?
There is. So, thyroid cancer has an unequal distribution where women are affected almost 2 times as often as men. So about 70% of our thyroid cancer patients are women, and 30% are male.
And we have no reason to know why that's like that?
No, there's not really a good explanation, unfortunately.
Okay. Probably down the road we'll figure that one out. And I'm sure when we figure it out, it'll be from the Rutgers Cancer Institute with several of their clinical trials, figuring out what's what. So before we close out this production, let's hear from each of you. Tell us a little bit about what someone should be thinking about if they've been given the diagnosis of thyroid cancer, and why it's so important that they come to you at the Rutgers Cancer Institute or at Robert Wood Johnson University Hospital in New Brunswick, or even Robert Wood Johnson Hospital in Somerset, so that they can get the proper treatment.
Yeah, so obviously having a new diagnosis of thyroid cancer is scary for anyone. The primary treatment in thyroid cancer is surgical removal of that portion of the thyroid that's affected, whether it be a part of the thyroid or the whole thyroid. And I think for anyone who's been diagnosed with thyroid cancer, the most important thing you could do is find yourself a high volume surgeon. And, you know, there are certain people who have a mixed practice where they, do a little thyroid surgery and then they do some hernias or they do some other things. We are dedicated endocrine surgeons. This is all we do every day. We do thyroid, parathyroid, and adrenal surgery. So no matter where you choose to have your care, and I hope it's with us, just it's important to choose a team that has the experience and the expertise and has the best outcomes through high volume.
Dr. Laird, anything to end the show on?
No, I echo all of that. And the other thing that I tell my patients is that I think that thyroid cancer gets minimized a little bit, as you alluded to before, where people call it the good cancer. It's still cancer, but the good news is that the vast majority of thyroid cancer patients are cared for by having an operation to take out some or all of their thyroid gland, and that's it. It doesn't come back. So they need high quality coordinated care, and they need to have good operations. But aside from that, they're going to go on and live a very long, healthy life.
Thank you both for being here. Thank you for what you both do at Rutgers Cancer Institute, as well as Robert Wood Johnson University Hospital.
Thank you.
Thank you for having us.
That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 844-CANCERNJ. For more information about cancer services at RWJBarnabas Health, please visit us at www.rwjbh.org/beatcancer.